A recent study shows that ACE2 is highly expressed in the mouth and the tongue, which may facilitate viral entry into the uninfected individual. In the lungs, ACE2 is expressed primarily in the lower lungs on the alveolar epithelial cells. The high infectivity of SARS-CoV-2 is primarily attributed to its ACE2 binding affinity. A single mutation at the receptor binding site enhances its binding efficiency to ACE2 receptors compared with the 2003 SARS virus. There are two phases of the clinical response induced by SARS-CoV-2 infections. Stage 1 involves the incubation and non-severe stages of the disease. The incubation period begins at exposure and can last up to 14 days, with most cases ranging from 4 to 5 days. At this time, an adaptive immune response is mounted in the majority of patients to eliminate the virus and prevent progression into severe stages of the disease. In the mild form of COVID-19, patients can develop mild symptoms like coughing, fever, and shortness of breath as the immune system works to clear the infection. In healthy patients with no underlying health conditions, this protective immune response is unimpeded, and patients typically recover within 2 weeks of symptom presentation. In stage 2 of the clinical response, if the immune response is impaired, the virus propagates and destroys infected tissues. Within 5 to 8 days of presenting with symptoms, patients can develop more severe disease. Once SARS-CoV-2 has infected most of the ciliated alveolar cells, their major function of clearing the airways is impaired. Subsequently, debris and fluids accumulate in the lungs, causing pneumonia with fever, cough, dyspnea, hypoxemia, and bilateral infiltrates on chest imaging. In the severe stage, chest CT scans can show ground glass opacities with or without consolidative abnormalities with bilateral and peripheral distribution and can involve the lower lobes. Less common findings include pleural thickening, pleural effusion, and lymphadenopathy. Recovery time in the severe stage of COVID-19 can range from 3 to 6 weeks. The tissue damage in the lungs triggers an inflammatory response, leading to increased macrophages and granulocytes circulating. In laboratory findings, high leukocytes, pro-inflammatory cytokines, serum D-dimer levels, erythrocyte sedimentation rate, or ESR, and C-reactive protein, or CRP levels have all been observed. This inflammation is the main cause of life-threatening issues in the critical stage, causing fluid to build up in the lungs and possible cytokine release syndrome or cytokine storm that damages other organs. Autopsies have confirmed that the lungs are filled with a clear liquid jelly. Hyaluronan is associated with acute respiratory distress syndrome, or ARDS, and hyaluronan has been implicated as the major contributor for this fluid buildup. Elevated levels of inflammatory cytokines such as IL-1 and TNF, or tumor necrosis factor, are observed in the lungs of patients with COVID-19, and these are strong inducers of hyaluronan production. Acute respiratory distress syndrome, or ARDS, is a major complication in critically ill patients. ARDS is characterized by the rapid onset of widespread inflammation in the lungs and diffuse alveolar damage. Symptoms include short, rapid breathing and cyanosis. These patients often require mechanical ventilators or extracorporeal membrane oxygenation, or ECMO, to support life. Patients that are over 65 years or have other comorbidities such as diabetes and hypertension are more likely to develop ARDS. ARDS can lead to death and can damage other organs also.